Alright, we're going to go ahead and start in chapter 30. There are a couple of YouTube videos for you to watch before you listen to this lecture. Also be sure and read the chapter. But let's go ahead and get started. Chapter 30 starts on page 724. Now this is just an image here of the liver and biliary system. So we see the liver has kind of that larger organ there, the gallbladder. And you can see how the liver with their two ducts combine with the gallbladder's duct into the common bile duct, which dumps into the intestine there. You can see that the liver is very vascular, much more vascular than a lot of the other structures within the GI system. The liver itself has a lot of canals that run through it as far as blood and bile is concerned. So we have the branch of the portal vein and the branch of the hepatic artery that go through all these sinusoids and lead into the central vein to the hepatic veins. So it just kind of circulates through multiple times, kind of getting all of those medications and all of the toxins metabolized out of our body. So the liver sinusoids, this is where all of it happens as far as the blood mixing and being metabolized, pulling those drugs out, all of the chemicals from the blood, and then all of the sinusoids come together and empty into one vein. So then we see it being circulated through and excreted out through the kidneys after that. We also have bile canals within the kidney because at the back end of each of those hepatic cells, we have bile released into the bile canals. It's carried to the bile duct and then to the gallbladder where it can be stored to be excreted as it's needed when we eat foods. So true or false, gallbladder stores bile that has been produced by the liver. I feel like I just gave this away to you. The answer is true. So remember, the liver makes that bile, secretes it to the small intestine via that common bile duct. If we have excess bile being secreted by the liver, it's stored in the gallbladder. So there are lots of metabolic functions of the liver. One, of course, is bile production. The other one is bilirubin excretion. And then we see drug and hormone metabolism also happening in the liver. So either detoxifying the body or inactivating those drugs. That's what the liver really does a great job doing for us. The other thing that our liver does is help with carb, protein, and lipid metabolism. And if you look on page, I gotta get turned to it so I can tell you the right page here, 728, it really breaks it down very nicely on the top of that page as far as how each of those are broken down by the liver. So this is a good example of using that picture on page 728 and how we break down our food for energy, but when we eat too much sugar, too much fats, how that can build up within our arteries because our liver just can't metabolize all of it. So Mr. M had a donut for breakfast. Explain how the sugar and the donut left in his small intestine and ended up as fat in his carotid artery. So remember, if we are eating too much fat, too much sugar, it's not going to be able to metabolize all of that for energy. It's going to have to go someplace else. So which of the following substances makes bile more susceptible to digestive enzymes? Is it carbs, protein, fat, or all three of these? Let's see the answer here. If you want to pause the video and find it for yourself, that would be great. But the answer is C, fat. Bile produced in the liver kind of emulsifies that fat, so they're easier to digest. So bile really works on getting rid of fat in our system. Now we have to look at bilirubin because that's a big job of the liver. Hemoglobin, remember from old red blood cells, we talked about this several weeks ago, becomes that unconjugated bilirubin. What happens though in the liver, it turns into conjugated bilirubin, therefore it's bile now and we can get rid of it. But if we have an excess of unconjugated bilirubin, meaning, we've had red blood cells, we're breaking too many of them down, whatever the issue may be, we see this as a buildup of bilirubin, and then we see this in our patients as a symptom of jaundice. So why would a man with liver failure develop jaundice? Because we're not able to make that conjugated bilirubin. Remember, our liver's not working correctly, and the liver is what links that unconjugated bilirubin in the blood to glycuronide, which turns it into bile. And if our liver isn't functioning properly, we're not going to be able to do that. So we're going to have a buildup of bilirubin in the blood, which is going to cause jaundice in our patient. So this is a pretty good picture of jaundice. There are certain areas that we want to look at as far as seeing jaundice and that yellowing. Eyes are a really good place. Mucous membranes are also a really good place under the tongue, but probably places that aren't as good would be hands, the palms of your hands and your soles of your feet. Not great places to look for jaundice, because sometimes they're discolored a little bit anyway. So what causes jaundice? Hopefully this is a very easy question for you. And of course it's increased bilirubin levels. And you guys can pause the video and read that rationale for yourself, but I feel like we've already talked about it enough. Cholestasis, this is bile flow into the liver slows down. It accumulates and forms a plug in the duct. So the duct can rupture and cause liver damage or damage to the liver cells. The liver is unable to continue processing the bilirubin. So then we have an increase of those bile acids in the blood and skin, and that causes pruritus or itching. So we will see the yellow in their skin, and the patient will also have itching because of those bile acids in the blood and in the skin. So now we got to break it down into all of the different types of hepatitis. And I do feel like at this point, in the past, you've probably thought hepatitis is fairly confusing. A, B, C, D, and E. So hepatitis A is listed here for you. B is listed here for you. Now the next one listed, hepatitis B associated delta virus. This is hepatitis D. So, and then we have C and E. What's interesting though is the different types of hepatitis, how they're transmitted. We do need to remember that hepatitis with a vowel comes from the bowel, so usually the transmission there is fecal and oral. We can vaccinate against hepatitis A, but if our patient is to catch hepatitis A without being vaccinated, now they are immune. Hepatitis B is transmitted in blood, semen, and saliva, and we absolutely do have an immunization for that, and that's what we all got before starting a nursing program or before working in a hospital. Hepatitis C, most often transmitted in blood and semen, no vaccine for that. And hepatitis B or D, there is no vaccine for that, but remember this is a super infection with B, and this is transmitted in blood. Now if we look at the signs and symptoms, treatment, and diagnosis, all of those are very similar, especially the signs and symptoms and treatment, because we're just dealing with inflammation of the liver. Now, it could be from different types or strains of hepatitis, but the signs and symptoms are the same. Same with treatment. Now, the diagnosis is done by a lab test, so we see that specific antibody in the blood. So whether it's A, B, C, D, or E, we'll see what's really causing that. So once again, hepatitis with a vowel comes from the bowel, so that'd be A and E are both from the bowel. So which hepatitis viruses are most likely to be the problem in an asymptomatic drug abuser? How about a nursing student that has spent 2 months volunteering in an orphanage in Mali? What about an infant whose mother has hepatitis? So take the time right now, pause the video, turn to page, let me get you to the right page. That way it's easier to look them up. Starting on page 732 is where the different types of hepatitis begin, and it goes over the next few pages. Look through and see which one is more likely with each type of hepatitis. And really just find that evidence, highlight that evidence in the book. Which of the following is the least virulent strain of hepatitis? Is it A, B, C, or D? And I'll give you some time to look that up. You can pause the video if you'd like. The answer here is hepatitis A. It's most commonly transmitted by that fecal-oral route. Usually contaminated food, poor hygiene, doesn't typically have a chronic stage like B, C, and D. B, C, and D are the most difficult to treat. So chronic viral hepatitis, this would be typically caused by B, C, and D. And most likely this is the main reason for liver transplant in adults. So we have Miss B, who's prescribed an oral medication for her skin problem. She took it twice a day. The day after she started taking the medication, Miss B drank wine with a friend right after taking her prescribed dosage. She got terribly ill. She said, I drink that kind of wine all the time, so she doesn't understand why she's not feeling well. We do have to remember that most metabolism of medication and alcohol is done in the liver. So if the liver is already doing a job, like metabolizing her new medication, it's not going to be able to metabolize the alcohol. So a lot of times that's why we say don't mix medication and alcohol, because the liver's going to have to make a choice to decide which to metabolize. And usually it metabolizes the medication and not the alcohol right away. Alcohol liver disease. So what we see with that a lot of times is a fatty liver. The liver itself will be enlarged with that. With alcoholic hepatitis, we have liver inflammation and liver cell failure. And then we also have an issue with cirrhosis. And cirrhosis is actually scar tissue of that liver that's starting to block off the blood flow and the bile flow within the liver itself. So here's some issues with our patient with cirrhosis. We see jaundice. We see mental status changes because of the buildup of toxins in their system. We see spider angiomas because remember how the liver helps to regulate our PT and INR, so we're going to have some bleeding issues as well. Ascites within the abdomen, a big liver, a big spleen, could have hemorrhoids. We have the edema related to the albumin, same with the ascites. Remember, we don't have the albumin within the bloodstream anymore, pulling that fluid back in, so it's kind of leaking out. So portal hypertension, that's what we were just talking about, and you can see each of the symptoms that we were just talking about linked to a specific cause. So ascites caused by that increased pressure in the peritoneal capillaries because we don't have the albumin within the system to pull it back in. Development of collateral channels due to shunting of blood. So same things going on there. So this slide just really kind of draws it all together for you, those signs and symptoms and why they're happening. So we do have veins that drain into the hepatic portal system. It can cause pressure on those veins to increase. So this is where we see those collateral channels and shunts developing from. And we have a lot of other organs engorged with blood because remember how much blood goes in and out of the liver, and if it's not able to do that, it's going to have to go someplace else. And that's why we see that spleen being enlarged as well, because remember how much blood it stores and kind of takes care of within the spleen itself as well. Liver failure also causes a lot of hematological disorders, anemia, thrombocytopenia, leukopenia. It also causes endocrine disorders related to fluid retention, hypokalemia. There are some other hormones that cause those disorders you may want to look into in your book. Skin disorders we've talked about quite a bit. We also have issues with azotemia, so having an increased BUN and creatinine. We also have issues with not having urine production. The other issue that can arise is hepatic encephalopathy, and this is a hepatic coma. So we see changes because of this increased blood ammonia level. We have changes in level of consciousness. It progresses from confusion to stupor to a coma. We have neuromuscular disturbances. We have their hands flap. And the treatment for that would be to decrease the protein in the diet, give lactulose and neomycin. So the problem of hepatic coma can be increased by eating too much protein, having an infection, having low vitamin or low potassium, a GI bleed. So just a lot of things can really precipitate that. So we need to be watching out for that with our patients with liver failure or liver issues. So now we're kind of getting away from the liver. We're moving to the gallbladder. And probably most of us know somebody that's had gallbladder issue if it's not been our own issue. Inflammation can be caused by the concentration of the bile because it's not being able to get out because of gallstones or other issues. We can actually have stones in the common bile duct that can cause some issues with bile getting by, and that causes pain. Cholecystitis, so this is inflammation of the gallbladder. Typically what we have to do is eventually get that gallbladder taken out. We can see jaundice, fever, increased white blood cell count. They don't want to eat. They're not able to tolerate fatty foods very well because remember that bile really helps break down those fatty foods. And if we don't have the bile being released into our system, we're not going to be very tolerant of eating fatty foods. They always have this feeling of fullness. Their abdomen is distended because the bile isn't there to help break down the food better. And we can see the type of pain that they have. Abdominal pain, right upper quadrant, maybe even epigastric, can radiate. So this slide is just a quick reminder of what the bile actually does in the intestine. It emulsifies the fats so they could be easily digested. It passes on to the large intestine, actually losing some of that in the feces. That's what gives it that brown color. And then a lot of it is actually reabsorbed back into the blood, returned back to the liver to be reused, eventually filtered out by the kidneys as urine. Our pancreas has exocrine jobs and endocrine jobs. The exocrine pancreas releases digestive juices through a duct into the duodenum. The second bullet here should say endocrine pancreas releases hormones like insulin into the blood. So the exocrine pancreas, you can see all of the jobs that it does here. So basically, what it really, its main job here is to secrete those digestive enzymes to activate those so that it can help break down food better. So true or false, the exocrine pancreas produces insulin. The answer here is false. The beta cells of the endocrine produce the insulin. Exocrine are the digestive enzymes. Autodigestion of the pancreas. So we have activated enzymes begin to digest the pancreas cells. We have severe pain that can result from that. And then our patients can actually become hypovolemic. The enzymes that we need to watch for, if we see an elevation of amylase and lipase in the blood and our lab values, we really need to be looking at the pancreas. It could be pancreatitis or something else going on within the pancreas there. And then we have issues of hypocalcemia. So areas of dead cells undergo fat necrosis, calcium from the blood deposits in them, and then we have low calcium in our circulating blood, but calcifications are going to be happening within the pancreas. Chronic pancreatitis and pancreatic cancer, very similar signs and symptoms to acute pancreatitis. Digestive problems, glucose issues, usually diabetes, even issues with biliary obstruction, maybe even tumors compressing that duct as well. All right, so that concludes our lecture for the liver. So if you have any questions, you can email those to me or bring those to class with you the next time we meet. See you soon.